Hello dear students. So let us start straight away. Yes. So of course we have curated this paper in such a way that maximum of the important topics of INI-CET get covered. Okay. So let's start. So with our first question. So the alternate way to measure height in a 4-year-old child is, right? So is it head circumference, knee height, crown rump length or arm span? So I am sure most of you have marked it correctly. So it cannot be head circumference. Head circumference usually, does not give you a very good idea about how much the height of the child is going to be. Now knee height, there's nothing called knee height as such, but there is something called, sitting height. So if you measure this sitting height, as you can see here, if you measure this sitting height, this sitting height gives you an idea about the upper segment. And it will help you in calculating the upper segment lower segment ratio, which tells you whether it is proportionate short stature or disproportionate short stature, right? Now arm span, what is arm span? So arm span is, as you can see in this figure, in this blue arrow, you can see that if you ask a child to outstretch the arms and you measure the distance from the tip of one middle finger to the tip of other middle finger, then you can measure the arm span, okay, with the arms at 90 degrees to the body. Now, arm span is almost equal to the height of a child. The difference between them is usually less than 3 centimeters. Now, this difference can increase in certain situations where the limbs are disproportionately long, like in Marfan syndrome. Okay. Now, so arm span definitely is the best answer here. It will give you an idea about the height of a child, right? What is this crown rump length? So crown rump length, so we can see before coming to the other parameters, so crown rump length is something that is the most accurate way to get an idea about the gestational age of a baby using ultrasound of a fetus, right? So crown rump length is usually done in the first trimester ultrasound. It is the most accurate method for assessing the gestational age. It is the dating scan. And it gives an accuracy of plus minus 3 days done in the 6 to 10 weeks period. Okay. Now, what about this upper segment, lower segment ratio? So, we need to have an idea about the normal upper segment, lower segment ratio at different ages so that you can interpret whether it is, which segment is affected in a child with short stature. So, at birth, what is the upper segment, lower segment ratio? So, normally it is 1.7 to 1.9 is to 1. At 3 years of age, it becomes 1.3 is to 1. And by 7 to 10 years of age, it becomes 1 is to 1. So, this is the normal upper segment, lower segment ratio at different ages, right? Now, what about the normal rate at which head circumference increases? So, this has also been asked previously. So, we need to know the normal rate. So, at birth, the head circumference is usually between 33 to 35 centimeters. In the first 3 months after birth, the head circumference increases at the rate of 2 centimeters per month. Next 3 months, it increases at the rate of 1 centimeter per month. Next 6 months, it increases at the rate of 0.5 centimeters per month. And next 2 years, it increases at the rate of 0.2 centimeters per month. So, you can see that the maximum increase in head circumference is taking place in the first year of life. And at any point of time, if you see that the head circumference has increased by more than 2 centimeters in any given month, then that is abnormal. And you need to look for the underlying causes of rapid increase in head circumference, which could be like hydrocephalus, right? Which could be a CNS tumor, which could be an intracranial bleed. So, you need to look for the underlying abnormality, right? So, moving to the next question. So, it is a very easy question on developmental milestones, but you get these match the column kind of questions in INI-CET, which add a level of difficulty to these questions. So, first let us discuss some important developmental milestones and we come back to answer this question, right? So, among the important gross motor milestones, the milestones that you cannot afford to not remember. Neck control, we know partial neck control comes at 3 months of age, complete neck control by 5 months. Sitting with support will come at 6 months, without support 8 months. After sitting, what will come? Standing. So, standing with support 9 months, standing without support will come around 12 months. In between around 9 to 10 months or 10 to 11 months, you have crawling and then creeping and so on. Okay, crawling followed by creeping. Walking with support comes at around 12 months, without support around 13 to 14 months. Riding a tricycle has 3 wheels, so 3 years, right? So, these are the gross motor milestones. Moving on to the fine motor ones. Now, when does a child hold an object when placed in hand? Again, around 3 months of age, tries to reach out for objects at 4 months and holds the object with both the hands, bidextrous grasp around 5 months of age. Palmar grasp or unidextrous grasp using one hand at 6 months. Once the child has held the object in one hand, can transfer objects from one hand to another at 7 months. Immature pincer grasp at 9 months, mature pincer grasp at 12 months. Scribble spontaneously like this at 15 months. Tower of 6 to 7 cubes, the age into 3 is number of cubes put in tower. So 2 years, tower of 6 to 7 cubes, right? Handedness appears at 2 years and gets established by 3 years. So lot of important milestones get covered here, right? Drawing skills of a child. So we know a child can copy a straight line has 2 edges, so 2 vertices, so 2 years. Rectangle, 4 vertices, copies a rectangle at 4 years. Circle at 3 years and triangle at 5 years, right? Important social milestones. Social smile we know comes around 2 months of age. Mirror play, the child plays with his or her own mirror image at 6 months. Stranger anxiety 7 months. Waves bye-bye is a very important milestone around 9 months of age. Plays peekaboo 10 months. Plays a simple ball game at around 12 months. Points to objects, okay, points to objects at 15 months. Domestic mimicry 18 months and daytime continence. Parallel play at 2 years, joins in play and plays with other children at 3 years, goes to toilet alone 4 years, right? And important language milestones, the child starts vocalizing at 2 months, cooing or a more musical sound at 3 months, monosyllabic babbling like ma, ba, da at 6 months, bisyllabic babbling mama, baba, dada 9 months but without meaning, 2 to 3 words with meaning at 1 year, okay? Jargon speech at 15 months, 10 words with meaning at 18 months, 2-word sentences. So, number of word put in sentences is age in years. So, 2-word sentences at 2 years, 3-word sentences at 3 years and so on, and tells a story, rhyme or sings a song at 4 years, right? So, these are some very important milestones that we need to know. Now, coming back to our question. So, social smile we know comes at around 1 to 2 months, right? So, 1 with A. Pincer grasp 9 to 11 months. Walks 1 to 2 steps would come at 12 to 13 months and transfer objects at 6 to 7 months. So, our best option here becomes, so 1 with A, 2 with C, okay, 3 with D and 4 with B. So, option D becomes our best answer here, okay. So, moving ahead to our next question. So, we have a 9-month-old infant, okay. So, a 9-month-old infant who is brought to the pediatrician with a concern that the child cannot sit without support. So, sitting without support, you remember it came at what age? Yes, try to recollect. So, sitting with support, we said sitting with support around 6 months of age, sitting without support around 8 months of age. But remember, there is a range of time for each milestone. Sitting without support should come at 8 months. That doesn't mean that at 8 months, 10 days, if the baby is not sitting without support, you think it is developmental delay. No, okay. So, 9-month-old infant cannot sit without support, that's okay, but the child is able to roll over, says mama, dada, stranger anxiety is there. So, all the other milestones around 7 to 8 months are there. So, what will you do? Immediate referral for developmental assessment, order an immediate MRI, that would be too drastic, reassure the parents that this is normal for age, or initiate physiotherapy. For answering this question, we need to remember that there are something called developmental red flags, okay. So, developmental red flags are there, that means there is an upper age limit for attainment of some of the milestones, right. If by that time also that milestone has not come, then it is abnormal, okay. So, sitting with support, we said for example comes at around 6 months of age. If it has not come by 9 months, then it is abnormal. Similarly, sitting without support comes at 8 months. If it has not come by 10 months only, then it is abnormal. So, if a 9-month-old baby is not able to sit without support, we will not call it abnormal. Similarly, standing with support, we said it comes around 9 months. So, the red flag is around 12 months. Standing without support comes at 12 months, red flag around 17 months, and walking without support 13 months. So, the red flag is around 18 months. So, in this case, what we will do is we will reassure the parents that it is normal for age and you need to, keep a watch on the baby. And if the child is not able to do that even after 10 months, then probably we should initiate a formal developmental assessment and further evaluation. Okay. So, HEADS assessment is done for. So, what is HEADS assessment? So, HEADS is an acronym. Yes, waiting for your answers. So, HEADS assessment, HEADS is an acronym. Yes, I can see Mansi answering. Good. So, HEADS stand for, so it is an acronym, it stands for Home, education, activities, drug use, suicidality, and orientation about sex and matters related to it. So whenever you encounter an adolescent, you are supposed to do the heads assessment because these individuals are in a vulnerable age group. So you need to address all these issues even in a otherwise well adolescent. So heads assessment is definitely done for an adolescent, not for a neonate, infant or a child. Okay. So it is a standard assessment done for adolescents. Moving ahead to the next question. Which of the following statements regarding breastfeeding technique are incorrect? So don't forget to see it is asking incorrect and not correct. Okay, incorrect. Okay, so let us see the statements one by one. The infant's lower lip should be inverted during latching. Should it be inverted? No, it should be everted or turned out. So this is incorrect, but don't jump and answer the question. Read all the options first. Okay. The infant's cheek should appear full during effective suckling. That's correct. If suckling is happening properly, milk will get accumulated in the oral cavity. So the cheek should appear full. A greater portion of areola should be covered above the breast than below. No, that's incorrect. The entire areola should go in the baby's mouth except a small upper part which may be visible. Okay. So it should not be, the entire areola on the upper part is usually not covered. So this is incorrect. An infant's chin should make contact with breast during feeding is correct. So the incorrect statements are, A and C. So our best answer becomes option A, right? What are the signs of good positioning while breastfeeding? So the entire body of the baby should be well supported, not just the head. Entire body should be well supported. The occiput, shoulder and buttocks of the baby should be in a straight line. Okay. So the posture should be proper. It should be in a straight line, right? The baby should be turned towards the mother, not just the head. The entire body of the baby should be turned towards the mother, okay? And abdomen of the baby should touch the abdomen of mother. So the baby should be closely held by the mother, okay? So these are the signs of good positioning while breastfeeding. What about the signs of good attachment? So the mouth of the baby should be wide open. It's not like the mouth is just open this much and only the nipple inside, then effective suckling will not happen. So mouth of the baby should be wide open. Lower lip of the baby should be everted or turned out, not inverted. Okay, everted or turned out. Entire areola should be in baby's mouth except a small upper part which may be visible. Small upper part. And chin of the baby should touch mother's breast. So these are the signs of good attachment or latching while breastfeeding. Now, why are we so, hell-bent on making breastfeeding work? Because the breast milk is perfectly suited for the baby. Breast milk's composition is such that, it is perfectly suitable for the newborn baby. How? So, breast milk has got more carbohydrate as compared to the cow's milk, almost 7 gram per dl as compared to 4.5 gram per dl in cow's milk, right? So, more energy as carbohydrates. What about proteins? Breast milk has got lesser protein than cow's milk, okay, lesser protein. So that, it does not produce a lot of solute load on the kidneys. But the protein is such, it is whey protein, which is more easily digestible, like lactalbumin, okay. While in cow's milk, it is casein, which is not very easily digestible. What else? Breast milk contains all the, essential amino acids. Essential amino acids like cysteine, taurine, methionine, which are required for the CNS development of the baby, which is not there in cow's milk, okay, right? What about lipids? So, breast milk is richer in polyunsaturated fatty acids, PUFA, which are good for the baby, and DHA or docosahexaenoic acid, which is required for the CNS development of the baby, right? What about minerals and vitamins? So, the calcium phosphate ratio in breast milk is such that it favors calcium absorption. But a baby who is exclusively cow milk fed, what will happen? So, cow milk is richer in phosphate, So, the baby will have more chances of hypocalcemia. And both breast milk and cow's milk is poor in iron, but the iron present in breast milk is more easily absorbable. Okay, right? What about the vitamins? So this has come as a question previously. Breast milk contains adequate amounts of all the vitamins except vitamin D, vitamin K and vitamin B12 in strictly vegan mothers who don't even take cow's milk. Okay. Apart from that, of course, breast milk contains a lot of substances that protects the baby's immunity, like, phagocytic macrophages, IgA, transforming growth factor beta, human milk oligosaccharides, lactoferrin, and so on. Okay. Now, moving ahead, another very important topic, malnutrition. So, which of the following best categorizes marasmus in terms of its clinical features and nutritional effects? So, marasmus is a condition where the baby is emaciated, there is no edema. So, marasmus is a condition where there is mainly calorie deficit, not much of a protein deficit, okay? And there is no edema. So, high lipid content, edema and low protein levels, no, we know there is no edema in marasmus, okay? Calorie deficit with normal plasma protein levels. So, calorie deficit is there and plasma protein levels are usually normal, that appears to be correct. Presence of edema and low protein levels, no. And high energy levels, of course, it's not there, right? Now, let us see from a given case scenario, how do you distinguish whether it is kwashiorkor or marasmus, okay? In kwashiorkor, of course, there is edema. Edema is present, but in marasmus, edema is absent. In kwashiorkor, so you have mainly protein deficiency. So, protein as well as calories are deficient. Protein and calories are deficient, while marasmus, it is mainly the calories are deficient. There is not much of deficiency of the proteins, right? Appetite. What about appetite? So, in kwashiorkor, the baby has a very, very poor appetite. The baby does not want to eat anything at all. But in marasmus, the child has a voracious appetite, wants to eat anything that comes in front of the baby. Voracious or very good appetite. CNS involvement is present in kwashiorkor. So, the baby has apathy or lethargy. The baby is not interested in surroundings. But marasmus, as such, you do not have CNS involvement. Fatty hepatomegaly is present in kwashiorkor, not present in marasmus, because in kwashiorkor what is happening? Protein is deficient. So, lipoproteins are not there to carry away the fat from the liver. So, fatty hepatomegaly. Skin and hair changes are also more common in kwashiorkor than marasmus. What is the skin change in malnutrition? We know it is flaky paint dermatosis. What is the hair change in malnutrition? It is the flag sign. Okay. Now, there is another WHO classification of malnutrition related to which you can get questions. So, in WHO classification, we look at weight for height and height for age and whether edema is there or not. So, weight for height, if it is between -2 to -3 z-score or between 70 to 79% of expected, it is called wasting. If it is less than -3 z-score or less than 70% of expected, what is it called? Severe wasting. Okay. And remember, wasting is the best indicator of acute malnutrition. It indicates acute or short-term malnutrition. Now, what about height for age? So, height for age between -2 to -3 z-score or 85 to 89% of expected is called stunting. And if it is even lesser than that, it is called severe stunting. And stunting or decrease in height for age indicates chronic malnutrition. So, this has also come as a question previously, right? Okay. Moving ahead to our next question. So, chronically malnourished, okay. So, a malnourished child develops hypokalemia and hypophosphatemia after receiving a high calorie diet. So, a child probably who has not been on very good diet for quite some time developed this. What is the most likely physiological mechanism responsible for these electrolyte disturbances? So, what are we dealing with? So, in this scenario, when a malnourished child is suddenly given, a lot of high calorie diet, what is going to happen? So, this is refeeding syndrome, or it is also called nutritional recovery syndrome. And the basic underlying defect here that is going to happen is sudden insulin release. Let us see what happens in refeeding syndrome and why. So, in nutritional recovery or refeeding syndrome, if you do aggressive refeeding, what will happen? Now, a lot of glucose is getting generated, excessive insulin release will be there. What will insulin do? Insulin is an anabolic hormone. So, excess protein and glycogen synthesis will take place. This will utilize excess of thiamine. So, thiamine deficiency will be there, which causes beriberi and which causes cardiac failure. So, cardiac failure is there, edema is there, and there is increased uptake of potassium, magnesium and phosphate inside the cells. So, there is hypokalemia, hypomagnesemia, hypophosphatemia. So these will also aggravate the cardiac failure, the edema, and because of cardiac failure, respiratory distress can happen. Because of hypokalemia, arrhythmias can happen, and the condition of the baby, instead of improving, worsens, right? So the inciting factor, of course, is the excessive insulin release, okay? So moving ahead, what is the best indicator of some dehydration in SAM? What is the SAM? First, so SAM, you get a question in every other exam. So SAM is severe acute malnutrition. We all know. How is it defined as? So in a child 6 months to 5 years of age, presence of one or more of, so we look at weight for height. So weight for height less than 70% of expected or less than minus 3Z score, okay? Or mid upper arm circumference less than 11.5 centimeters, or symmetric bipedal edema of nutritional origin, okay? Symmetric bipedal edema of nutritional origin. So if any of these is present, we call it severe acute malnutrition, right? So the best indicator of some dehydration in SAM. So what happens in a malnourished child is there is a loss of buccal pad of fat, there is a loss of subcutaneous fat from everywhere practically. So even if the child is not dehydrated, you can still get sunken eyes. So sunken eyes you can still get even if there is no dehydration. Thirst, of course, will not get affected by whether the child is malnourished or not. Lethargy, again, remember we said in kwashiorkor, the child has apathy or lethargy. So even if the child has no dehydration, in kwashiorkor, apathy or lethargy is still there. So we cannot take it to indicate dehydration. Again, because of the lesser subcutaneous tissue, if you do the skin pinch test on the abdomen, you can find that, there is decreased, the skin pinch is not going back to the normal form, right? So the best answer is thirst here. So I can see most of you answering. So B, thirst is the best answer here. Moving ahead, treatment non-responsive SAM or severe acute malnutrition. Treatment non-responsive SAM includes all except. Okay, so but before that, let us see what is this treatment of severe acute malnutrition, and then of course we can decide whether the child is responding to treatment or not. Okay, so for a child who is severe acute malnutrition is there, you have to do initial hospitalization for most of the patients, especially those with poor appetite or medical complications. Okay, or complications. What will you do once you've admitted them? Look for the complications and treat. So if there is hypoglycemia, you have to give 10% dextrose. You can give either using a nasogastric tube or you can give IV symptomatic. Hypothermia, you have to cover the baby and heat up the baby, change the wet clothing and so on. Infections, you need to give antibiotics, okay? Electrolyte imbalances, you need to correct. You need to supplement potassium, magnesium and all the electrolytes in which the child is deficient. For correcting dehydration in a child with SAM, what will you use? Yes, what do you use to correct dehydration? We do not use the normal ORS. What do we use in SAM? Waiting for your answers. So we use, yes, we use Resomal or rehydration solution for malnourished child, which has got lesser sodium, more potassium and micronutrients. And for deficiency of micronutrients, again you need to supplement. But remember, iron is not given in the initial phase. It is given only later in the rehabilitation phase. Otherwise, it interferes with the recovery or healing. Now, nutritional rehabilitation, of course, we start with low calories and proteins. And we gradually build it up, okay, to prevent the nutritional recovery or refeeding syndrome. That is how you manage a child with severe acute malnutrition. When do you discharge them from hospital? So, the child should be accepting well orally, okay? The appetite should have improved. The child should have lost edema and started gaining weight, okay? Of course, the weight will not come to normal, but at least he has started gaining weight. All infections and micronutrient deficiencies should have been treated. And mother should be confident of taking care of the child at home. Only when all these criteria are met, you can discharge these children from hospital, okay? Right? Now, treatment failure in severe acute malnutrition is indicated by, so what will happen? If your child is not responding to treatment, the appetite will not improve, the edema will not disappear. So, failure to regain appetite by day 4, failure to start losing edema by day 4, or if the edema is still present on day 10 or the child is not gaining at least 5 gram per kg per day by day 10. If any of these is present, we call it primary failure. What about secondary failure? Secondary failure means initially the child was responding, but later in the rehabilitation phase, the child is no longer gaining adequate weight. Okay. So these are the criteria for failure to respond to treatment in a child with severe acute malnutrition. Coming back to our question, treatment non-responsive SAM includes all except. So no edema reduction by day 4, yes, that is treatment non-responsive SAM, yes. Appetite not increased by day 4 again indicates the child is not responding to treatment. Weight for height reaches -2 Z-score. That of course will not increase, indicate that the child is not responding. The child is responding. So weight for height has increased from -2, from less than -3 Z-score, it's come to -2 Z-score. Weight gain less than 5 gram per kg per day by day 20. So that also again indicates the child is not responding to treatment. So because except is there in the question, so our best answer is option C here. So slightly complicated question. So, but these are the criteria for when the SAM child is not responding to treatment. Okay, and we saw what the treatment is. Moving ahead, poor gonadal development is seen in which micronutrient deficiency? Is it vitamin A, vitamin C, zinc or iron? So yes, micronutrient deficiencies remain a very important topic. So a few micronutrients and their deficiency features, let us see. Vitamin A, we know its deficiency causes night blindness and it causes, all sorts of xerophthalmia. You have the entire WHO grading, but the earliest symptom of vitamin A deficiency is night blindness. While the earliest sign, what is it? So earliest sign is conjunctival xerosis. So the option can state anything, it's not necessary. Even at day 20 also, if the child is not gaining 5 gram per kg per day, then also, it will indicate treatment non-responsive SAM, right? It will be secondary failure to respond to treatment, okay? So, vitamin A deficiency earliest sign we said is conjunctival xerosis. What is also important is the dose of vitamin A used in treatment. So, if the child is less than 6 months age, you give 50,000 international units per day. If it is, 6 months to 1 year, you give 1 lakh international units, and more than 1 year, you give 2 lakh international units, provided the weight is more than 8 kgs. And you give a stat dose, repeat after 24 hours, and repeat a third dose 2 to 4 weeks later. Thiamine deficiency we know causes beriberi, which can be wet beriberi, which has features of heart failure, edema, dry beriberi, which has neurological features. Riboflavin deficiency will cause angular cheilitis, right? Angular cheilitis, stomatitis, oral ulcers, aphthous ulcers, and so on, right? It can also cause some conjunctival abnormalities as well. Niacin deficiency we all know causes pellagra. Pellagra is a disease of 4 Ds, diarrhea, dermatitis, dementia, even death can happen. And you can have Casal's necklace, a rash around the neck. You can have photosensitivity and so on, right? 4 Ds. Pyridoxine deficiency can give rise to neurological features, and in neonates or infants, it can cause refractory seizures. Refractory seizures in neonates or infants, okay? Right, very good. And cobalamin deficiency, vitamin B12 deficiency, again it can cause either megaloblastic anemia or it can cause neurological abnormalities, the subacute combined degeneration of spinal cord. Biotin deficiency is another important disorder in children. You can get case scenario wherever you're getting CNS findings plus skin findings. Think of biotin deficiency. So you can have, a child with seizures, there could be developmental delay, right? And you can have skin rashes, alopecia, think of biotin deficiency, right? Okay. Zinc deficiency can have poor gonadal development. They can be, acrodermatitis enteropathica, so a rash around the orifices can be there. There can be diarrhea, poor wound healing and so on. Okay, right. All of the following are incorrect about resuscitation of a critically ill child except. So, incorrect is being asked. Okay, so don't forget to see whether correct is being asked or incorrect. Okay. Chest compression depth should be 1/3 of anteroposterior diameter of the chest. Yes, we know chest compression depth should be 1/3 of anteroposterior diameter of chest is correct during resuscitation of a child as well as a neonate. Compression to ventilation ratio should be 30:2 with 2 rescuers. What do you think? Is it correct or not? Right? So it is incorrect. Let us see what should be the compression to ventilation ratio. So ratio of chest compression to positive pressure ventilation in neonatal resuscitation, if you talk about, it should be 3:1 and nothing else. But in a child, okay, in a resuscitation of a child, with one rescuer it should be 30:2. With two rescuers it should be 15:2. Okay, 15:2. So coming back to our question, so with two rescuers the ratio should be 15:2 and not 30:2. So this is incorrect. Injection adenosine 0.01 ml per kg IV or intraosseous. No, we give injection adrenaline in resuscitation. Okay, so 0.01 ml per kg of 1 in 10,000 or 0.01. So we give 0.1 ml per kg, we give adrenaline 0.1 ml per kg of 1 in 10,000 or 0.01 mg per kg. Okay, right? Preferred route is intraosseous. No, preferred route is always intravenous. Only when you are not able to secure IV access, you give intraosseous. So all of the following, you can see B, C and D are incorrect. So all of the following are incorrect except. So our best answer becomes option A, which is the correct option here. Okay. Moving ahead, identify the inheritance pattern in a pedigree chart. Now, whenever you are getting a pedigree chart, 3 golden rules. First thing you see is whether all children of an affected female are affected. Yes, so if you see here that this female is affected, but all her children are not affected. This is not affected, this is affected, this is not affected, this is affected. So it is not mitochondrial inheritance. In mitochondrial inheritance, all children of an affected female are affected. Mitochondrial out. Now, whether it is dominant or recessive, if you can see wherever a child is affected, one of the parents is affected, then it is dominant. So you can see that these two children are affected, this parent is affected. Again, these two children are affected, this parent is affected. This child is affected, this parent is affected. So it has to be what? It has to be dominant. Okay, it has to be dominant. Now, whether it is X-linked or autosomal, so in X-linked inheritance, remember, there cannot be father to son transmission. If father to son transmission is occurring, it has to be autosomal. Because father's X chromosome never goes to the son. Father's Y chromosome goes to the son. Understanding it? So the concept behind it is very, very important. So here we can see father to son transmission. Can you see that this father has the disease? Okay, this father has the disease and this son also has this disease. So father to son transmission rules out X-linked inheritance. So this is autosomal dominant, right? Now we understand what is autosomal recessive, X-linked recessive. X-linked recessive males will be more commonly affected. What is this pseudo-dominant? So Akash, the dose of adrenaline in children, we use 0.1 ml per kg or 0.01 mg per kg. But in neonatal resuscitation, the dose has been recently revised. In neonatal resuscitation, the dose of adrenaline is now 0.2 ml per kg or 0.02 mg per kg. Is it clear, Akash? Yes? Okay. So what is this pseudo-dominance? Pseudo-dominance is a condition which is actually not a dominant inheritance. It is basically autosomal recessive inheritance, which is behaving as if it is dominant, right? So what do you mean by pseudo-dominance? So see, this is an autosomal recessive condition where this female is homozygous, okay, this female is homozygous for a condition and this male is heterozygous. The male is a carrier for this condition. So if only the female would have been affected, all the children would have been carriers in an autosomal recessive disorder. But here, because the female is affected and the husband is also a carrier for the same disorder, then you can have children who are affected. So it will appear that it is dominant inheritance because this female is affected and her mother is also affected. It appears that it is dominant inheritance, but it is not dominant because even though this female is affected with the autosomal recessive disorder, the male is also a carrier for the same disorder. So that is why the children, instead of being only carriers, they can get one defective gene from the father, one defective gene from the mother and can get affected even in an autosomal recessive disorder. So even though it is autosomal recessive disorder, it is looking like it is a dominant one. So this is called pseudo-dominance. When one individual is affected and the other is a carrier and they mate together. Okay, then you can have children who are affected with the autosomal recessive disorder, right? Okay. Now, which of the following is a X-linked dominant condition? So let us see the inheritance pattern of some of the important diseases. So spinal muscular atrophy, SMN1 gene deletion, it is a autosomal recessive disorder. Duchenne muscular dystrophy is a classical example of X-linked recessive disorder. Males are more commonly affected. The less severe variety is called Becker muscular dystrophy. Some other X-linked recessive disorders like hemophilia, Bruton's X-linked A-gamma globulinemia, and so on. Rett syndrome is a classical example of X-linked dominant inheritance, while achondroplasia is a classical example of autosomal dominant inheritance where the limbs are disproportionately short, short-limb dwarfism, large head is there, trident hand is there, champagne glass pelvis is there, and so on. Okay. So X-linked dominant inheritance are most, the best answer here is Rett syndrome. Okay. Yes. Okay. So Rett syndrome, it is more common in, so we said it is X-linked dominant inheritance, so it is more common in girls. The most common gene mutation, lot of gene mutations are known, most common one is MECP2. What happens to the head circumference? At birth, the head circumference in these individuals is normal. But slowly there is deceleration of head growth and there is acquired microcephaly. What else? They have developmental delay and they have stereotypic abnormal hand wringing movements. So they will move their hands like this. So abnormal stereotypic hand wringing movements are there. It can be associated with seizures, breathing difficulties, and so on. Now recently in the INI-CET exam, one question had come, which is the most recent FDA approved drug for Rett syndrome. The answer is trofinetide. So it is the recently approved FDA approved drug for treating Rett syndrome. Okay, trofinetide. Right, very good, Akash. Okay, which of the following is not seen in Down syndrome? So Down syndrome we know is a disorder where there is trisomy 21. So 3 copies of chromosome 21. So there is hypothyroidism associated in this disorder, hearing loss is seen, short stature, it is a very important cause of short stature, but webbed neck is not a feature of Down syndrome. Webbed neck is a feature of Turner syndrome, right? So these are some of the features of Down syndrome that you can see. Right, so you can see here, you can see the sandal gap. What do you see here? Short incurved little finger is called clinodactyly. This is the simian crease, the single transverse palmar crease. You can see the depressed bridge of the nose. Okay, so depressed bridge of the nose. You can see this is the epicanthic fold over the medial canthus and the protruded tongue that is there. The ears may be dysplastic. You have a flat occiput, large anterior fontanelle, right? And you can see there can be some brush field spots on the iris as well. Right? So these are some of the manifestations of Down syndrome. You can get a karyotype report also. So karyotype picture, you can see that there are 3 copies of chromosome 21 here. So this is trisomy 21. And you can see that there is 1 X chromosome and 1 Y chromosome. If you were to write this karyotype, written notation had come in the exams once. So that would then be, if you count the total number of chromosomes here, instead of 46, it is going to be 47. And you have XY, so it is a male with Down syndrome, and you have 1 extra chromosome 21. So that is how you write it. Okay, clear? Moving ahead, which of the following features is not typically associated with Turner syndrome? So Turner syndrome we know is a condition where 45XO, a single X chromosome, no Y chromosome. So in this condition we have short 4th metacarpal and metatarsal is there, widely spaced nipples are there, webbed neck we already mentioned is there, but abnormal head shape is not a feature of Turner syndrome. And in Turner syndrome, remember, there is normal intelligence, okay? Normal intelligence. Abnormal head shape you can get in mainly 2 situations. One is, which is called plagiocephaly. Plagiocephaly means there is asymmetric flattening of one side of the skull, which is mostly due to postural issues, right? And you can get abnormal head shape in craniosynostosis. What is craniosynostosis? It is abnormal, premature fusion of 1 or more sutures. So you can get like dolichocephaly, you can get turicephaly, oxycephaly, and so on, right? So craniosynostosis. So those are the conditions where you can get abnormal head shape, but not in Turner syndrome, right? So Turner syndrome, the basic defect we already mentioned is that there is single X chromosome, no Y chromosome. Because there is a single X chromosome, because there is no Y chromosome, so that is why what happens, it is always seen in girls, never seen in boys, right? Now girls normally have, 2 X chromosomes, so they have normally 1 bar body. Bar bodies is, the number of bar bodies is number of X chromosomes minus 1. But in girls with Turner syndrome, you will have 0 bar body. Even though they are girls, you will have 0 bar body, right? Most common congenital heart disease in individuals with Turner syndrome, it is, yes, what is it? So it is bicuspid aortic valve. If that is not there in your options, then the next most common is coarctation of aorta. Okay, coarctation of aorta. And remember, Turner syndrome is a very important cause of short stature, right? Apart from short stature, you can get other features like, there is lymphedema of hands and feet. Cystic hygroma is more common in this condition. Hypothyroidism is more common. You can get shield-shaped chest with widely spaced nipples can be there. And there can be low posterior hairline like you see here. There can be this webbed neck. Can you appreciate the loose skin folds around the neck, the webbed neck? And you have streaked ovaries and rudimentary uterus. So these individuals also have primary amenorrhea and they are infertile. So there is infertility. Turner syndrome, we said, is always seen in females. Can you name a similar syndrome which is seen in males? So similar syndrome which is seen in males is, yes, it is Noonan syndrome with similar features. So similar features in males if you get, then it is Noonan syndrome. But what are the differences? Noonan syndrome, there is intellectual disability is there. There is delayed puberty, but fertility is normal. And the most common heart disease there will be pulmonary stenosis. Okay, and it has autosomal dominant inheritance. Now, this is the karyotype in a typical child with Turner syndrome. If you count the total number of chromosomes here, it will be 45 instead of 46. And there is a single X chromosome and no Y chromosome. So, 45 XO, right? Now, match the following. So, again, it is a very easy question. You can see that one more thing to note here are that these three, the first three are aneuploidies. Okay, they are aneuploidies. Aneuploidy is a condition where, the chromosome number is not an exact multiple of the haploid. That means the haploid number for humans is 23. Normally, the number of chromosomes is 46. But when the number of chromosomes becomes, say, 47 or 45, we call it aneuploidy. So, these are aneuploidies, but sickle cell anemia is not aneuploidy. Clear? Okay. Now, trisomy 13 we know is what? So, it is Patau syndrome. So, 1 with D. Trisomy 18 E for E, we know it is Edwards syndrome. Trisomy 21 is Down syndrome and sickle cell anemia is glutamin valine replacement in the 6th position of the beta globin chain. So, our best answer is 1 with D, 2 with B, 3 with C and 4 with A. So, option A is the best answer here, right? So, these are the features that you get in trisomy 13 or Patau syndrome. Patau syndrome is a very, dreadful kind of disorder, almost usually fatal. So, you can see scalp defects which are called cutis aplasia. You can see that there is holoprosencephaly underlying this patient. So, you can find, cleft lip, cleft palate. Sometimes there will be a single nose in the form of a proboscis. Sometimes there will be a single eye. You can see the limb defects that can be there. And you can see the polydactyly or the extra digits that are there. Okay. And you can see here the holoprosencephaly, the defect in the abnormal cleavage of the cerebral hemispheres. Yes, it is usually not compatible with life, right? So, that is why if it is a confirmed case of trisomy 13 or Patau syndrome, we do not resuscitate the child. Same goes true for anencephaly, where there is absent, cranium and absent scalp and the brain is exposed to outside. This is the child with Edwards syndrome. Edwards syndrome or trisomy 18. So, you can get image based questions. Can you appreciate this rocker bottom foot which is just convex here, just like a rocking chair. So, it is the rocker bottom foot. You have overlapping digits, overlapping fingers and toes that can be there. There is microcephaly and of course, internal malformations like, you have brain abnormalities, heart abnormalities, kidney abnormalities and so on, right? What is this? Tell me, what is your diagnosis here? So, if you see closely, you have, yes, waiting for your answers. So, you have all the chromosomes, you have 2 copies except for chromosome 18 where there are 3 copies. So, it is trisomy 18. Is it an aneuploidy or not? Yes, trisomy 18 or Edwards syndrome, is it an aneuploidy or not? So, we already mentioned aneuploidy refers to a condition where a cell's chromosome number is not an exact multiple of the haploid number. Trisomy 18, 47 chromosomes. So, it is a aneuploidy, yes, okay. Right. Enzyme deficient in Pompe disease. So, Pompe disease is a form of glycogen storage disorder type 2 GSD where mainly muscle is involved. We know it is acid maltase or it is also called alpha glucosidase. Okay. Glucose 6-phosphatase is deficient in which disorder? We all know glucose 6-phosphatase deficiency is von Giarke disease, right? Muscle phosphorylase deficiencies, McArdle disease, where it can present in adolescents with myoglobinuria, exercise fatigability, calf muscle pain and so on. Phosphofructokinase deficiency is Tarui disease, which is also muscle GST, okay, type 7 GST. Now in Pompe disease, you will get hypotonia or a floppy child. No neck control even at 6 months. You can get cardiomegaly because in Pompe disease what happens? Abnormal, it is a lysosomal storage disorder. Abnormal substance accumulates in the lysosome of various organs, especially heart and skeletal muscles. So there is hypertrophic cardiomyopathy, there is cardiomegaly, floppy baby, you can see ECG changes like short PR interval and tall QRS complexes. And the management of Pompe disease, you have enzyme replacement therapy available. Enzyme replacement therapy is also available for other metabolic disorders like Gaucher disease, okay. It is available for mucopolysaccharidosis like Hunter disease, Hurler disease, right, and Morquio disease. So it is also available for Fabry disease, Niemann-Pick disease. So for all these disorders, you have enzyme replacement therapy available as of now, okay. Now this 1-year-old child, so we have a 1-year-old child here who presents with hepatosplenomegaly and is found to have a cherry red spot on retina. So we are dealing with a storage disorder. Hepatosplenomegaly is there, cherry red spot is there. Exhibits a normal startle reflex but shows developmental regression. What do you mean by developmental regression? Developmental regression means loss of previously attained milestones. Developmental delay means the child is gaining milestones late. But regression means once he has attained the milestones, he lost it. Okay, so that is regression. Chest X-ray reveals bilateral pulmonary infiltrates. Based on these clinical features, which of the following enzymes is deficient? So, hexosaminidase A deficiency is seen in Tay-Sachs disease. But can it be Tay-Sachs disease? In Tay-Sachs disease, we do not get hepatosplenomegaly. So, it cannot be Tay-Sachs disease. Sphingomyelinase deficiency is Niemann-Pick disease. Yes, Niemann-Pick disease has got hepatosplenomegaly, cherry red spot and has pulmonary involvement also. So it can be Niemann-Pick disease. Glucocerebrosidase deficiency, it has, we know it is Gaucher disease. Gaucher disease will have splenohepatomegaly but no cherry red spot. Phenylalanine hydroxylase deficiency would be phenylketonuria. There you will get hypopigmentation but no cherry red spot and so on, right? So cherry red spot with organomegaly with pulmonary involvement. We'll think of sphingomyelinase deficiency or Niemann-Pick disease. If there would not have been any pulmonary involvement, we would also have kept GM1 gangliosidosis as our DD. Tay-Sachs disease is also called what? GM2 gangliosidosis. Don't confuse on that. Okay. So Tay-Sachs disease we said is also known as GM2 gangliosidosis. Okay, and there is no organomegaly. Cherry red spot is present. Cherry red spot is present, but no organomegaly. Okay. You can get exaggerated startle though. Niemann-Pick disease, you get cherry red spot, you get organomegaly or hepatosplenomegaly, okay, and you get pulmonary involvement. And recently, enzyme replacement therapy has become available for Niemann-Pick disease. Gaucher disease, very, very important disorder. Enzyme replacement therapy has been available for years together. There is splenohepatomegaly. It is one of the causes of massive spleen enlargement. Spleen is so huge, it has come beyond the umbilicus. Massive spleen enlargement. The Gaucher cells will go and infiltrate the bone marrow, causing pancytopenia because of anemia, easy fatigability, recurrent infections, bleeding because of thrombocytopenia, bone pains, neurological involvement may or may not be there. Okay, and these are the Gaucher cells that you can get in bone marrow and in other organs of the reticuloendothelial system. Okay, what happens in phenylketonuria? So in phenylketonuria, remember we said it is phenylalanine hydroxylase deficiency. This enzyme is deficient. So what will happen? Excess of phenylalanine will accumulate in our body and that will cause brain damage. So you will have hypertonia and intellectual disability and so on. Now, excess of phenylalanine will get converted to metabolites like phenylacetate and phenylpyruvate. Okay, they give a typical mousy or musty kind of body odor. So, mousy or musty odor is what you can get. What else? Now, because tyrosine is not getting formed, this enzyme is deficient. So, tyrosine is not getting formed. So, tyrosine becomes an essential amino acid, which you have to take from outside, cannot be synthesized in body. Now, because DOPA is not getting formed, from DOPA melanin is formed. Melanin is also not getting formed. So, the child will have hypopigmentation. So your concept should be very, very clear, then you do not have to mug up things, right? So we can remember all the features of phenylketonuria so easily, okay? Moving ahead. So you have an assertion reasoning kind of a question. Mousy odor is seen in phenylketonuria. Is it correct? Yes, we know it is correct. Mousy odor is seen. Decrease in tyrosine and dopamine and noradrenaline. So tyrosine is not getting formed, dopa is not getting formed, and melanin and noradrenaline are not getting formed. So this statement is also correct. Yes, but this reason is not the correct explanation of the assertion. The mousy odor is not because of the decrease in tyrosine, dopamine, noradrenaline. The mousy odor is because of accumulation of excess of metabolites like phenylacetate, phenylpyruvate. So our best answer here is option D. So both assertion and reasoning are correct, but reasoning is not the correct explanation for assertion, right? Okay. So in INI-CET, we get a lot of these assertion reasoning kind of questions also, where you have to apply the facts that you have learned, okay? So that's why very important to have strong concepts. Now, match the following. So Cori disease. So let us first discuss a little bit about glycogen storage disorders and we come back to this question. So the glycogen storage disorders can be either disorders in which mainly liver is involved or mainly muscle is involved. Liver glycogenosis include 1, 3, 4 and 6. Type 1 is Von-Guericke disease. We already mentioned it is glucose 6-phosphatase deficiency. Type 3 or Cori disease is D branching enzyme deficiency. You remember C with D, and what is special about it is both liver and muscle is involved. Liver and muscle both are involved because D branching enzyme is deficient. So a branched, an abnormal branch structure is going to accumulate in the liver. Clear? Okay. Anderson disease, you can remember A with B, so branching enzyme deficient. Hers disease, remember hepatic phosphorylase, H with H. Hers disease, hepatic phosphorylase deficiency. Now the muscle glycogenosis, you can remember 2 plus 5 is equal to 7. So type 2 or Pompe disease is alpha-1,4 glucosidase deficiency, or we also call it acid maltase. And we already said it is a lysosomal storage disorder. Abnormal substance accumulates in the lysosomes, causes hypertrophic cardiomyopathy, floppy child and so on. McArdle disease type 5 muscle phosphorylase, M for M. And you have calf muscle weakness, easy fatigability, myoglobinuria and so on. Can present even in adolescents and adults. Thyroid disease is phosphofructokinase deficiency. Coming back to our question, yes. So Cori disease, what will happen? It is D branching enzyme deficiency. So a branch structure will accumulate, will be seen on liver biopsy. McArdle disease, exercise intolerance. Pompe disease, accumulation of glycogen in lysosomes. And Von-Guericke disease, hypoglycemia with lactic acidosis. So our best answer will be A with 1, B with 3, C with 2 and D with 4. So option B is the best answer here. So all the very best. God bless you. Good night. Take care. Study hard. Be sincere.